Good day and welcome to this webinar on bone health in hematologic stem cell transplant patients. I'm Dominique Pierrot, Science Manager at IOF, and I'm delighted to be the moderator of today's webinar. Before introducing the speaker of the day, I would like to inform you that attendees are automatically muted. I would like to encourage you to ask your questions during the webinar by typing them into the question box of the control panel, and I will voice them to the speaker towards the end of this webinar. This being said, I have the great pleasure to welcome today Professor David Candler, who is Professor of Endocrinology at the University of British Columbia Faculty of Medicine and the Director of the Osteoporosis Center of British Columbia and ProHealth Clinical Research in Vancouver, Canada. Professor Candler's primary clinical and research interests are osteoporosis, metabolic bone disease, men's health, and autoimmune thyroid diseases. He is a member of the Committee of Scientific Advisors of the IOF and the past president of the International Society of Clinical Densitometry. Professor Candler has published over 150 publications in peer-reviewed journals on osteoporosis therapies, osteoporosis risk assessment technologies, and autoimmune thyroid diseases. Professor Candler, thanks again for having agreed to speak today. We are delighted to have you with us, and we are listening to your presentation.
Okay, thank you very much, Dominique. It's my pleasure to talk to you today about bone health in hematologic stem cell transplant patients. And we in Vancouver have a very active stem cell transplant program, and so we've had an opportunity to look in detail at these patients and in particular at aspects of bone health. Furthermore, the International Osteoporosis Foundation has a bone and cancer working group, which I'm a member of, and I was pleased to chair the group who looked in particular at this topic, bone health in hematologic stem cell transplants, and published a recent review, and I'll highlight some of the features of that in the presentation. So what I seek to do today is to first talk a little bit about the epidemiology of bone health, bone density, and fractures in hematologic stem cell transplant patients. And then we'll talk about the risks for bone loss in these patients, following on what we can do to protect bone and an algorithm which through our bone and cancer working group of IOF, we derived to help guide clinicians as to how to manage bone health in these patients. So there are, of course, increasing numbers of allogeneic stem cell transplant patients as we see that technology being applied to different hematologic malignancies. Furthermore, with large international registries of potential stem cell donors, there are many more patients who might be able to get accurate or close matches, and so the volume of stem cell transplant patients is increasing. As well, we have improved acute care and improved chronic care, which increases the survival of these patients. And with increased survival, of course, we are concerned about the long-term outcomes. And at least in our unit and many others, we have specific programs to address these long-term issues. We know that bone loss is most rapid in the first 3 to 6 months after stem cell transplant, with the greatest loss occurring at the hip, suggesting cortical bone loss in excess of trabecular bone loss. So this is an interesting nuance about bone loss in the stem cell transplant patients. And we know that fragility fractures are a very serious complication of stem cell transplant. And just to remind people that fractures are not benign events. They often take away from quality of life, and especially in these transplant patients who have sometimes multiple other health concerns to do with the transplant and graft versus host disease, fragility fractures are a major issue in these patients' course. So early on, we recognized that stem cell transplant did lead to bone loss. So if you look at the graphic on the bottom there from 2006, we can see that stem cell transplant patients early on had declines in hip bone density approaching 9 or 10% in the first 6 months of therapy, and then things largely plateaued. And in these early studies, pamidronate was used, and you can see observationally that patients who got pamidronate infusions had less of a decline in bone density. Still, they had declines of 4 or 5% in bone density, but not so acute as those patients who were not given pamidronate. And some of the data, the earlier data suggested that about 30% of stem cell transplant survivors had osteopenia, and up to 52% had osteopenia at the femoral neck. And so highlighting again that the issue of cortical bone loss being perhaps greater than trabecular bone loss. Also in the long-term studies, some trials or observational data suggested that the early rapid bone loss would be incompletely recovered at hip. Spine may increase somewhat more than hip. So our own data, we, as I said, have a very active stem cell transplant group in Vancouver, and we looked at a 4-year interval between 2011 and 2014. We looked at 137 stem cell transplant patients retrospectively, and all of these patients had, according to our protocols, a baseline and a day 100 bone density test. And what we found is that in the first 100 days after stem cell transplant, spine bone density decreased an average of 3%, hip bone density 4.6%, and femoral neck bone density 4.7%, again highlighting the greater declines in bone density at hip site than at spine site, and quite remarkably fast decreases in bone density, given that this is only a 3-month interval. And we noted that the diagnosis of osteoporosis by bone density increased from 12% at baseline to 18% at just 100 days post-transplant, osteopenia increasing from 41% to 50%. So again, highlighting this early decline in bone density. And then we looked at some of the risks for that decline. Women had greater loss than men. Glucocorticoid logically was associated with bone loss at the total hip. And we looked at trabecular bone score, and day 100 TBS was significantly lower at baseline and lower in patients who had glucocorticoid exposure, as you might expect. For those of you who don't know trabecular bone score, this is a pattern analysis from the DEXA machine of lumbar spine, whereby if the pattern of trabecular bone is filled in and consistent, it would give you a preserved trabecular bone score, TBS, which is high. And if you have deteriorated architecture and an irregular pattern, then the TBS would show deterioration of bone. So it's a marker of bone structure. And in our stem cell transplant patients, the deterioration in TBS would certainly imply that at spine, in addition to those losses in bone mineral, there also is a deterioration in architecture. Another study here from Korea looked at patients over a 6-year time frame, a much smaller study than ours, only about 70 patients enrolled, and they found similar declines in spine and hip bone density. Again, the declines in hip bone density were greater than those at spine. In their case, they didn't see a significant change in TBS. There was a trend toward a deterioration. They were looking at baseline and 1-year studies. They saw, as they followed these patients out to 24 months, there were small increases in spine and total hip bone density, more so in spine than hip, between the 12 and 24-month time point, with no change in TBS. So another series from France looked at a large number of French patients, almost 260, between 2005 and 2016, and they had baseline 6 months and 3-year bone density, so followed out to a longer time point. And they found that 17% of patients met WHO criteria for osteoporosis at baseline. That increased to about 23% at 6 months. And then at 3 years, this observational study showed about 17% had a DEXA diagnosis of osteoporosis. And they followed out to look at fractures. They found at 6 months, 4.1% of these patients had had an incident fracture. That's a relatively high incidence of fractures at over just a 6-month time frame, suggesting the high burden of fracture that we have in these patients. And they found 5.7% of patients had had a fracture at the end of 3 years. They found some improvements in spine bone density at 3 years, and again, that was better than hip. So the decrease in hip is more acute and more substantial than spine, and the recovery is less. So this is a series from MD Anderson, where they have a much larger, the largest series of stem cell transplant patients and the longest follow-up. So they look back at these patients with a maximum of 15 years of follow-up in over 7,600 patients. They showed a recorded incidence of 8% of fractures. Perhaps some of these fractures would have been missed in retrospective studies, and they looked in particular at the relationship of fractures to age, the type of malignancy, and the type of stem cell transplant. So in the top panel here, you're looking at patients who are over age 50 in yellow versus those who are under age 50 at the time of transplant. And you can see that the cumulative incidence of fractures, as you would expect, is much greater in those patients who are older as compared to younger. The tumor type also had a major influence on fractures, and as you might expect, multiple myeloma had the greatest risk of fractures. Other hematologic malignancies and solid organ tumors had a lesser incidence of fracture. And then stem cell transplant type. Interestingly, the autologous stem cell transplant patients had much greater risk of fracture or incidence of fractures than those who are allogeneic. And that's maybe the opposite of what you think, because the allogeneic transplant patients lose a lot more bone than the autologous. But of course, the autologous transplant patients are the myeloma patients. And so I think we're seeing reflections of the type of tumor, hematologic malignancy, which predisposes to fracture more so than the stem cell transplant type. And they found that the fracture risk was 8-fold higher as compared to age and sex-specific fracture incidence rates from the US population. So they didn't have a control group, but they used controls from the US population. And that certainly is a substantial increase in fractures. In Taiwan, different geography, again, they looked at fractures. And they had 4,160 cancer patients who did not have a stem cell transplant, and just over 1,000 who did have a stem cell transplant. So maybe not the most appropriate control group. These were all cancer patients compared with largely hematologic malignancy patients. But they found that in those who got stem cell transplant, the relative risk of fracture was 1.4. And most of the fractures, about 70% in their series, were vertebral fractures. So moving on to the risks for bone loss in stem cell transplant patients. In our review, we reviewed the literature for what was determined as risk factors, and certainly, as I showed you, advanced age was a risk. Female sex, also a risk, females having more bone loss than males. Chemotherapy, the more intensive the chemotherapy, the greater the bone loss. Chemotherapy links into hypogonadism, as in it usually in females leads to hypogonadism, and so that also can be a risk for bone loss before the stem cell transplant. And then after the stem cell transplant, we have graft versus host disease, which is a potent factor inducing bone loss in these patients. We also have often calcium and vitamin D insufficiency And so these patients are often acutely ill after their transplant. They may get mucositis, they may have GI graft versus host disease, and they may have difficulties absorbing calcium and vitamin D acutely, and that would lead to secondary hyperparathyroidism, which can contribute, of course, to bone loss. Glucocorticoids are widely used in very, very high doses to suppress graft versus host disease, often for long periods of time, and that's a major factor after stem cell transplant in seeing both bone loss and risk of fractures. Some patients get into issues of renal dysfunction for a variety of reasons, including chemotherapy and immune suppressant therapy, and that of course has also an effect on bone loss. These patients may be treated with stimulators of neutrophil response, particularly if they're infected, and that may contribute to bone loss, as well as renal wasting of calcium and magnesium, often from medications that these patients take. The calcineurin inhibitors also have been reported to have negative effects on bone. We know that there is an interaction between the transplant stem cells and bone cells, perhaps mediated by cytokines, and the cytokines can stimulate rank ligand, which is a mediator of osteoclastogenesis. We see that in these stem cell transplant patients, there is evidence of decreased osteocyte viability, and that might have a role to play in bone loss. And we know that up to 20% of these stem cell transplant survivors have avascular necrosis that could be contributed to by their malignancy or by the glucocorticoid, which is used often in their management. But that also certainly is a risk to bone. And that brings up the burgeoning field of what has been called osteo-immunology. And that's the interaction between bone cells and immune cells. And this is an area of intense research and lots of new findings looking at the crosstalk between the immune system and bone cells. And when we're talking about bone loss, of course, the seminal pathway for osteoclastogenesis, osteoclast formation, function, and survival is the rank ligand osteoprotogerrin system, and that can be stimulated by many of the cytokines that we know are evolved after allogeneic stem cell transplant. And that includes TNF-alpha, IL-1, IL-7, IL-23, and other cytokines, which are going to be implicated in increases in rank ligand in the bone marrow environment and osteoclast formation and activity. And there are indeed some trials of mesenchymal stem cell infusion systemically in order to potentially benefit graft versus host disease, perhaps directly or indirectly. Those stem cell infusions may have benefits to bone health, or so it has been proposed, and many trials need to be done in this area to define whether there is a role for stem cell infusion. GM-CSF is used to induce mobilization of stem cells in donors, often after chemotherapy. Stem cell transplant patients require that as well. And this may increase the number of osteoclast precursors, and that may have a role in inducing post-transplant bone loss. I mentioned hypogonadism, and ovarian failure, very common in young women after hematologic stem cell transplant. Male hypogonadism, perhaps less common. And of course, glucocorticoids in high dose can give central suppression of gonadotropins and give secondary hypogonadism. And this loss of sex steroid in both men and women certainly can contribute to bone loss in these patients. So on to the evaluation of bone health in these patients. As with other osteoporosis patients or patients who may be at risk of fracture, we would start with a good history and physical and elicit the clinical risk factors important for bone health. Bone mineral density certainly plays a role in evaluating the pre-transplant and post-transplant course of these patients, but certainly that would be important prior to transplant. Spine radiographs may play a role in identifying vertebral fractures and stratifying those very high-risk patients pre-transplant for more intensive treatment and follow-up. And of course, these patients may also have other reasons for bone loss, issues such as hyperparathyroidism, perhaps absorption issues, celiac disease, etc. And so an evaluation for secondary cause of bone loss would be important pre-transplant. Can we use FRAX? So FRAX is a system, of course, for integrating clinical risk factors with bone density, and the clinical risk factors being age and sex, and menopause, prior fracture, parental hip fracture, cigarette smoking, alcohol, rheumatoid arthritis, as well as bone density. It doesn't incorporate falls, but that is another important feature of evaluating clinical risk factors. And this was looked at in the MD Anderson population recently, and they determined in their population that FRAX has only a moderate ability to predict fractures in their large population of stem cell transplant patients. So it may have some utility, but its utility is not as great as with, say, postmenopausal osteoporosis. So how do we manage these patients? Well, of course, we start with the basics, that is calcium, vitamin D, and perhaps menopausal hormone therapy. General nutritional support is important, as these patients are acutely ill after their transplant from chemotherapy. Often they require parenteral nutrition or enteral nutrition because of mucositis or graft versus host disease. Calcium and vitamin D nutrition is also important. Often they're unable to get calcium from diet, especially acutely, and so they may require supplements as in the early stages post-transplant. Our recommendation is 1,200 milligrams of calcium from the combination of diet and supplement, and that should be adequate in most of these patients. Vitamin D3 is important, of course, for calcium absorption, and we recommend 2,000 IU by supplement. But we consider that these patients often acutely may not be able to take a lot of oral medications, and so we consider a loading dose in patients. We did a little study of that, giving 100,000 IU of vitamin D3 as a loading dose pre-transplant, and we found that at 100 days, the 25-hydroxy vitamin D level was superior as expected to those patients who were just given 2,000 IU per day. And so you might consider a loading dose in patients, especially if you're anticipating issues in terms of graft versus host disease or mucositis. These patients often are acutely ill and not doing very much by exercise. We also have a little exercise study where we're encouraging these patients to do programmed or prescribed exercises post-transplant. We haven't yet got the data on that, but we expect, as with other tumor types, that a programmed exercise prescription for these patients will have benefits in terms of their recovery from transplant and return to good quality of life. And then finally, menopausal hormone therapy, estrogen, in appropriate patients, females who become menopausal and who are candidates for HRT can play a role both in quality of life and symptom management, as well as contributing to bone health. So what about vitamin D deficiency? There have been a number of studies looking at vitamin D levels in stem cell transplant patients. Of course, deficiency in vitamin D is contributed to by decreased sun exposure. These patients are acutely ill and not out in the sunshine, and many of them may get graft versus host disease affecting the GI tract, impairing absorption and impairing general nutrition. Glucocorticoid and the calcineurin inhibitors, as well as renal insufficiency, can also play a role in interfering with vitamin D metabolism. And in one study, the median pre-transplant 25-hydroxy vitamin D level was 40 nanomoles per liter, and that would be considered insufficient vitamin D pre-transplant. Another study showed 70% of patients were insufficient in vitamin D, highlighting the role of vitamin D supplements and perhaps even a loading dose for vitamin D. So onto bisphosphonates, and this certainly has proven to be the mainstay of treating these patients pharmacologically. I showed you data previously, early studies on pamidronate as an intravenous bisphosphonate, which played a role in attenuating the declines in spine and hip bone density. So declines in this particular study of about 5% versus 8% in those who did not get pamidronate. Those declines still substantial despite pamidronate therapy. So just one other slide on all of the data that we have on bisphosphonates. These were assembled in a recent meta-analysis, which looked at a number of the studies of using a variety of bisphosphonates, usually intravenous bisphosphonates, for stem cell transplant patients. Looking at, in the top panel, spine bone density, and you can see that the meta-analysis showed increases in spine bone density as compared to those not treated of about 8%. So that being favorable to the use of bisphosphonate at spine, and quite a similar response, about a 7% increase at femoral neck in those given bisphosphonates in this meta-analysis as compared to those who were not treated. So the trials are pretty consistent in showing a benefit of intravenous bisphosphonate in this population. And now generally the bisphosphonate is given at baseline if patients are at risk or have osteoporosis at baseline, and perhaps at a later stage at a year after transplant. But there has been some investigation looking at more frequent administration. I showed you the 100-day data, typically a time point when HSC patients are evaluated, and that would give an opportunity to look again at a bone density and perhaps administer further bisphosphonate. The Australian group looked at a much more aggressive zoledronic acid protocol, and this is Peter Ebling's group. They looked at 80 stem cell transplant patients, and their protocol gave them an infusion of zoledronic acid prior to the transplant. And then subsequently, they had an algorithm that they would, again, reinfuse them at day 100, day 180, day 270, so 4 infusions over the course of a year. But they would infuse according to a protocol. If those patients were on glucocorticoid, they would get the infusion, or if they had lost 5% of bone density from baseline, then they would receive a subsequent infusion. And indeed, most of their patients met one of those criteria and received frequent infusions through the course of the first year post-transplant. And this was a series. They didn't have a control group, but they did see that there was a lesser decline here in femoral neck bone density in those patients managed according to this algorithm, with many patients maintaining bone. And they proposed that this more intensive regimen of zoledronic acid infusion might be something which is reasonable in this high-risk population. And then they looked compared to historical controls, and they said that the femoral neck bone density was much better maintained than in those patients historically who did not receive such an intensive regimen. They also looked at graft versus host disease, and not unexpectedly in the dotted line here, patients with extensive GVHD had greater femoral neck bone loss than those who had either no GVHD or limited GVHD. And so graft versus host disease certainly plays a role as well in bone loss. So what about Denosumab? We know Denosumab is a rank ligand monoclonal antibody, and one might think that that would be an ideal agent to prevent such acute and substantial bone loss, especially cortical bone loss, where you want access to that cortical compartment. And Denosumab, of course, is given in high dose, that is 120 milligram each month to patients with malignancy which has progressed into their skeleton. And so the question has arisen, maybe Denosumab would be a good acute agent to prevent those declines. And there are very limited data as to the role of denosumab in this stem cell transplant population. This is a small series from Korea, 33 women. Unfortunately, they were all within 3 years of stem cell transplant, not acutely, and one might see the role of denosumab most germane in the first 6 months when we see those acute declines in bone density. And they found in these patients who were mean age about 53, given the usual osteoporosis dose of denosumab every 6 months, that they got an increase in spine bone density and femoral neck bone density consistent with what you might expect in postmenopausal osteoporosis. So not really answering the question, but showing that in this stem cell transplant population, denosumab can be effective at increasing bone density even later on after transplant. What about other therapies? Estrogen has been documented in many series to show an attenuation of post-transplant bone loss. So if estrogen is appropriate, and in particular with symptomatic women, that may play a role. SERM's milder anti-resorptive activity than estrogen or bisphosphonates, and no studies that I was able to find in stem cell transplant patients. Parathyroid hormone and its derivatives, of course, have an effect not just of stimulating bone formation as bone anabolics, but they also stimulate bone resorption. And that may be a risk, as bone resorption may release growth factors into the bone marrow, and that may be deleterious to the underlying tumor. That may be an advantage in terms of promoting engraftment, but because of this risk of perhaps stimulating the underlying malignancy, as well as the contraindication of teriparatide if patients have had prior skeletal irradiation, has led to no clinical trials of parathyroid hormone derivatives. Romosozumab is an interesting agent, of course, a sclerostin monoclonal antibody, and it has a dual action, both to stimulate bone formation and to inhibit resorption. And so this may be, as a monoclonal antibody therapy, one which has relevance in the stem cell transplant population, but as yet there are no studies published as to its use. So I'm going to finish up with our algorithm, and this comes from our bone and cancer working group. And we looked at 3 different time points in a patient's journey after stem cell transplant. The pre-transplant time frame when patients would be evaluated, the first 100 days when you might have reason to intervene, and then the day 100 time point. And as I mentioned, that's a common time point for reevaluation of these patients in terms of their hematologic engraftment, and a good opportunity to look again at their bone health. So let's look in greater detail at this. And in the pre-transplant population, we would look at the general measures which I mentioned, the calcium and the vitamin D and physical activity if possible. The initial assessment would include bone density, their risk factors, their menopause status, prior osteoporotic fractures, and a panel of blood work to rule out secondary cause of bone loss. And the bone density could be done pre-transplant, and we separated patients into those who had bone density which was higher than -1.5 at spine, total hip, or femoral neck, or less than -1.5. Where did that -1.5 come from? Rather analogous to glucocorticoid-induced osteoporosis. We, because of the anticipation of rapid bone loss, chose a cut point perhaps a little bit higher than for postmenopausal osteoporosis to give us an opportunity to intervene and prevent bone loss. And then during if a patient pre-transplant had bone densities of less than -1.5, we would recommend pharmacologic intervention, the proven therapy being zoledronic acid, possibly in the future with more studies, denosumab may play a role. And then in the first 100 days, if a patient has GVHD and goes on high-dose glucocorticoid, if they have not previously received zoledronic acid, they might, during those first 100 days, receive their infusion. And then our protocol suggested that a day 100 DEXA, repeat DEXA of hip and spine would be helpful. And again, then we would separate patients into those who had less than minus 1.5 T-scores, where a pharmacologic intervention could be delivered. That would be, again, zoledronic acid or Denosumab. And those who had better than minus 1.5 at day 100, a repeat DEXA and assessment 1 year post-transplant. So that we figured was a conservative algorithm to help us to prevent the bone loss common in these patients. So in summary, there's increased utilization of stem cell transplant for a great variety of hematologic malignancies and other conditions. And that requires that we focus on chronic and long-term outcomes in these patients. And we have improvements in both the acute and chronic care of these patients, so lots more long-term survivors to focus on long-term health concerns. And bone health is one of the more significant morbidities after stem cell transplant. So we feel that consistent and more aggressive monitoring and treatment of bone health in these stem cell transplant patients is required in order to improve long-term outcomes. So I'll finish up there and welcome any questions that you might have.
Thank you very much, Professor Candler, for this very comprehensive talk. I'm sure it was greatly appreciated by our attendees. Now I would like maybe, while people are typing their question, I will maybe start with this first one. You mentioned like glucocorticoid treatment for these patients. Some of them who have severe graft versus host disease may require a high dose of glucocorticoid. So how do you adjust for dose and duration of glucocorticoid treatment when you're estimating the fracture risk clinically or within FRAX?
Yeah, so as I mentioned, FRAX is perhaps only a moderate predictor of fracture in this population, and logically because it does not have stem cell transplant as a risk factor. And it also has just radio buttons for either steroid therapy or not steroid therapy, and often these graft versus host disease patients are taking 50 or 100 milligrams of prednisone per day, extremely high doses, and often for extended periods of time. And so we know that the effect of glucocorticoid on the skeleton is related to both dose and duration of therapy. And often the dose of therapy remains very high in these patients, often for a long period of time to get the GVH under control. So there are some adjustments to FRAX that you can make if patients are on greater than 7.5 milligrams of prednisone per day versus less than 2.5 milligrams per day. But in this population, those adjustments probably fall short of the mark. That is, we're using glucocorticoid far in excess of those potential adjustments. So I think you need to put on your clinical hat, and as with the Ebling protocol from Australia, if patients are on very high dose glucocorticoid, even consider more frequent than annual zoledronic acid infusion, they might be on more of an oncology dose of zoledronic acid where they're given an infusion perhaps every 3 months.
Thank you. So now Dr. Naranjo is congratulating you for your terrific talk. And he is asking whether the algorithm apply also to people younger than 40 years.
So we do have a variety. I showed you our series was average age about 52, but there are a lot of younger patients now undergoing this undergoing stem cell transplant. We did not examine pediatric patients. That's a totally different ballgame and not within the scope of what we did in our review or for our algorithm. But I would see that being appropriate to the younger age range patients as well, in particular because the females will become menopausal by and large after their chemotherapy and the transplant procedure. So we are talking about postmenopausal females. The males also, many of them do become hypogonadal, and I think many of the effects of stem cell transplant are similar in the younger versus older population. So we would probably see applicability of that algorithm to younger as well as older patients.
Dr. Lanfranconi is asking which drugs are off-label.
So I guess off-label depends a little bit on your perspective. Certainly, zoledronic acid has applicability and indication for patients who have postmenopausal osteoporosis at high risk of fracture, glucocorticoid-induced osteoporosis, male osteoporosis. So it has the full spectrum, and these patients, I think, would fit into one of those categories. Now, you might say, in particular, is there an indication for stem cell transplant patients? And that has not been submitted for a particular indication. But I think these patients fit under other indications, and I don't think we would look at either Denosumab or zoledronic acid as being particularly off-label. I suppose with Denosumab, given that there are no published clinical trials, at least with a control group, the safety of Denosumab is not yet documented, and its efficacy. So we would await some further investigations before, I think, widely applying Denosumab in this population. But it is an agent that does hold promise, and with further trials in this population, it may extend the ability beyond just zoledronic acid and intravenous bisphosphonate. And of course, Denosumab may have particular applicability in patients with renal compromise where zoledronic acid may not be feasible.
Thank you. There is a question from Dr. Papakitsu. She's asking, how much suppression of bone resorption do you want? Do you use bone markers to titrate the dose of zoledronic acid? And there is a related question from Dr. Ishalom, who is asking if you use bone turnover in the decision about treatment.
So we do not have access to bone turnover markers, so I do not speak from personal experience, and so we don't use them. We find bone density is probably adequate, and I did show that it is a marker. You might say bone density in many instances is a delayed marker of disease progression or treatment efficacy. But I showed you as early as 100 days, you can see quite dramatic effects on bone density. There are some studies out there which look at bone turnover markers, and as expected, the bone turnover markers are increased in patients as they're losing bone density. Do we use that to guide the use of zoledronic acid? We do not, and in the literature, to my knowledge, there isn't a lot of evidence. Again, drawing attention to the Australian study where they used that more intensive zoledronic acid protocol. They didn't use bone turnover markers to decide if further zoledronic acid was required, but they rather used the use of glucocorticoid in those patients, or decline in bone density as being a marker that they might be qualifying for a further zoledronic acid infusion. So we don't have a lot of data about bone turnover markers in that population. And it may be that there are factors in these complicated patients' course, including renal insufficiency, that would have some impact, some artifact on the bone turnover markers.
Thank you. There is another question from Dr. Bock. Is asking, was Denosumab an appropriate option in this patient with osteopenia to prevent further bone loss, taking into consideration that a rebound effect might occur after stopping Denosumab and this required further bisphosphonate treatment?
Yeah, that's a very good point. This is why more trials are required with Denosumab before promoting its widespread use. There's the question, what do you do after Denosumab? Would it be appropriate then to follow on with the zoledronic acid infusion? Would we have more efficacy in that acute 100-day period in preventing the cortical bone loss with denosumab? Perhaps yes, maybe it would require the oncology dose 120 milligram versus the osteoporosis dose 60 milligrams to have impact on that very rapid cortical bone loss. And maybe all you would need is a single dose, and there would be attenuation of the decline or prevention of the decline, and then the cytokine storm acutely after stem cell transplant would have settled, and maybe there wouldn't be a rebound after denosumab. These are all speculations, and I think highlight the need for clinical trials to see what happens in these patients and what appropriate protocols might be. But an excellent question.
Dr. Lanfranconi is asking whether you are aware of any specific guidelines for children and adolescents undergoing HSCT.
I'm going to have to plead ignorance on that. I'm an adult endocrinologist, and at IOF we did focus in our bone and cancer working group on the adult population. I said the pediatric population is a totally different story, and that because, of course, children are not just little adults. They have particular physiologies which require expertise. It's not just adjusting a dose, but it's thinking about the developing skeleton and the effects of both the pathology, the stem cell transplant on the developing skeleton, as well as the therapies. And I guess reassurance would be that with osteogenesis imperfecta and pediatric exposure to dose-adjusted amounts of intravenous bisphosphonate, the developing skeleton appears to not be greatly impacted. And so presumably bisphosphonates do find applicability, but I think that requires a specific pediatric algorithm, and I'll plead ignorance on that.
Thank you. Now, one question about vitamin D. Vitamin D insufficiency is quite common in patients undergoing HSCT. What loading dose regimen would you recommend?
Yes, so in Vancouver, we did a little protocol on that, thinking that often these patients aren't able to get the 2000 IU vitamin D daily in because they have severe mucositis or graft versus host disease of their GI tract, and that would preclude absorption. So we gave 100,000 IU of vitamin D3 orally pre-transplant when patients were prior to their chemotherapy and radiation. And we found that at day 100, those receiving the 100,000 IU loading dose and then 2,000 IU per day had higher 25-hydroxy vitamin D levels than those receiving just 2,000 IU per day. And given the innocuous nature of such a loading dose, we're not going to cause harm in these patients, we proposed that probably would be a good consideration, something perhaps to add on to our next version of the algorithm, is that in this particular population, a loading dose of vitamin D may better ensure vitamin D sufficiency through the course of these patients' post-transplant journey.
Okay, thank you. Another question related to vitamin D. We all heard that a very high dose of vitamin D have been proposed as a treatment for the cytokine storm with acute COVID infection. Can you speculate on the role of very high dose of vitamin D in these patients?
Yes, so it's an interesting concept that I guess Donald Trump received a very high dose of vitamin D when he was hospitalized for his COVID. Some of the theories about why vitamin D was proposed in COVID is that the COVID infection often brings on respiratory failure by release of a lot of cytokines, and it's actually not the virus, but rather the cytokines that induce the pulmonary damage that leads to these patients' requirement for ventilation. And one of the theories is that vitamin D may reduce the release of cytokines and may have a positive effect, a beneficial effect in in acute severe COVID infection. And there has been some literature proposing that maybe vitamin D has an effect in reducing graft versus host disease, and that it might have immune modulating effects or effects on inhibiting the release of cytokines. There have been no convincing clinical trials to date, but it certainly would be a consideration to prevent either graft versus host disease or the cytokine release, which activates the osteoclast and induces that very rapid cortical bone loss in the first 100 days post-transplant.
Thank you. Another question related to the diagnosis is, what are the indications for vertebral morphometry, lateral thoracic and lumbar spine radiographs in those patients prior or subsequent to HSCT?
Yeah, lumbar spine radiograph, or maybe easier, a VFA, vertebral fracture assessment study by DEXA, is a relatively simple thing to do. These patients have many procedures done, and that would give, I think, a good baseline. I did show that vertebral fractures are one of the more common fractures occurring, particularly in patients with graft versus host disease who are given high-dose glucocorticoid. And we can't very accurately identify who these patients are pre-transplant. So particularly in the older individuals over the age of 50 or over the age of 60, to do a baseline VFA or spine radiograph to identify vertebral fractures, that would allow targeting of therapy pre-transplant to those patients who are at very high risk of fracture. And it would give a baseline to see if new fractures are evolving subsequently. And again, that would impact on clinical decisions. So I think this is a high enough risk population for eventual glucocorticoid therapy for that rapid bone loss that we might, in the older population, do vertebral morphometry much more widely.
Thank you. So yeah, many thanks for all these questions and for clear responses. And now I think it's time to conclude. I would like to thank you all for your participation in this webinar, and we hope that you enjoyed this session. We will post the recording of this webinar on the IWF website, and you will receive your certificate of attendance and the link to the recording by email tomorrow. You will be prompted to fill in a survey immediately after this webinar. We would appreciate your input and comments. And if you have any questions, comments, please do not hesitate to send them at the address webinar@osteoporosis.foundation. I would like to thank you again, Professor Candler, for your outstanding talk. And I wish everybody a nice day, a warm day in European countries, or a nice evening or nice day to all of you. Goodbye.